Thank you very much, and welcome to the very, very beautiful historic city of Cambridge. Underneath that, you'll see the very new Addenbrooke's Treatment Centre, which is where Fiona and I, for actually a very, very long time now, predating this building, have held a renal genetics and tubular disorders clinic where for many, many years we've reviewed people with a wide range of diseases, but predominantly polycystic kidney disease. And so over that time, I guess we've developed our own way of working, and it's just to emphasize exactly what Fiona says, that we're giving you a snapshot of potentially how we do things, and that's not necessarily how it's delivered across the region, but the general information should, I hope, be broadly the same, but there may be differences and discrepancies. And I think one of the most important things from my point of view today is not to do this. We're very, very used to doing this blah, blah, blah approach and very, very didactic teaching, medical students, whoever. I think the issue that we would like to achieve today is to put out some general information, some general points, and use it as the opportunity to really stimulate questions of us and discussion between yourselves, and we'll just see how things progress. But if we do start doing the blah, blah, blah bit, please put your hand up and don't be compromising in your language. So, one of the first things that people often do when they come into our clinic is that I've been on the internet. If you go onto the internet and search PKD, you will get an enormous amount of information about polycystic kidney disease. You might find out about a very famous make of surf kite. You might also be accused of being a plane spotter. There is a PKD plane there. There's some very, very nice restaurants in London that come up when you search PKD, one called Powder Keg Diplomacy. And if you have £51,000, the Cambridge Porsche Centre will sell you a Boxster with PKD. I still don't know what PKD stands for. And if you're into films, Blade Runner, Philip K. Dick, who wrote the film, the gun that Blade Runner used is called the PKD gun. So you will get an awful lot of irrelevant and often inaccurate and I think slightly, in some circumstances, incorrect and frankly wrong information. The only reason I'm pointing that out is partly to flag wave for Tess, but I think it's incredibly important that if you do use the internet, you use very, very good, in a sense, kite-marked, if you will, sources of information. So the PKD Charity, I think in the UK, is very much leading on that. Most of you, I suspect, will have already been here, and you'll find the various tabs about providing accurate information about PKD. A lot of people involved with the charity, physicians who are talking today, for example, will have contributed to this sort of information, and this is the information we use in our clinic. And I think, if I'm right, Tess, that there will be an information booklet that's going to become available very soon, which will essentially mirror much of what I'm going to say today. So I'm just going to take little snapshots of information because we can't cover PKD in 20 minutes, the basics. We sometimes have conferences. We've just had a very, very big PKD conference in Edinburgh with about 120 international delegates, and it took 3 days to agree that we didn't agree on what to do with PKD. So this is the other question that we are very, very frequently asked when people come to clinic, is what does PKD mean for me? And we very often say this, and Fiona has just made the point that, in a sense, PKD is not one disease. It's incredibly individual, not just to the person with it, but also to the families of that individual. Why have I put this slide up? Well, partly to show that it's me up in the top right-hand corner. My wife would wish. These people are all exactly the same age as me. These people are also 99.99% genetically identical. But look at them. Look at how we vary as individuals. And this is exactly the same way that we vary in terms of the symptoms, the signs, the complications, for example, that individuals with PKD might have. So it's actually very, very difficult at the moment for us to say, you have PKD, this is how the condition is going to affect you throughout your life. The answer to that is we just don't know. We don't have good predictive tools, especially when we meet somebody at a relatively young age. Perhaps as you do get older, as you move beyond your 40s into your 50s and your 60s, our ability to predict does improve. But it is really just to stress the point that in a sense it is not one disease. It is one diagnosis, but not one disease. Many of you will be quite familiar with the concept of what the kidney does. We're all aware that this is essentially, or two kidneys, essentially a very, very sophisticated filter. What does it do? Well, it makes urine, dummies, what everybody says to me. It does an enormous amount. So it regulates the amount of salt and water in our bodies. It removes a vast amount of waste products. It's involved in hormone production, and those hormones control blood pressure, the amount of blood, hemoglobin that we've got, and how our bones are strengthened and healthy through regulating calcium. And of course, when all that goes wrong, you can start to see what happens in terms of abnormal blood pressure, maybe a bit of anemia, maybe a bit of bone disease, increasing in amounts of waste products in the blood, maybe salt and water problems. In terms of looking at the kidney in more detail, we know that, oh yes, here we go, it is working. We know what a kidney roughly looks like, but if we go down to the very, very smallest unit of the kidney, the functioning unit, it's this sort of tubular structure that we call the nephron, and it's really just capturing an image of the nephron. Actually gives us quite a good idea of what is involved in polycystic kidney disease. So just to go through it in a sort of a stepwise way, there is another sort of cartoon of the nephron. And this is what happens in polycystic kidney disease. We start to develop these little cysts, and they can occur, and we can have many, many thousands of these off each of these units, nephrons in the kidney. Over a very, very long period of time, and we're generally speaking about decades, what happens is that a few of these, we have about 1 to 2 million nephrons, but a few of these cysts actually become quite substantial in size. I've lost my pointer again. And so eventually, 1 or 2 of these cysts become big, and the number of these cysts increases over time. So we go from what looks like a normal-looking kidney to a kidney that has quite a large number of cysts in it. And then progressively what we get, if we were able to look at that over a period of time, and this is an image through somebody's tummy. This is a magnetic resonance image. No, it's a CT, sorry, on this one. And you can see I've outlined the kidneys in red here. And what you can basically see is that the kidneys gradually get bigger, more and more cysts appear. So in a sense, the amount of normal kidney tissue that is available to function gradually reduces over a period of time. And that largely predicts what happens in polycystic kidney disease. This is a surprisingly common problem. I'm not going to put up lots of numbers, and I'm not asking you to interpret all of that, but there's been some very, very nice work that a number of groups within the UK have been doing to really start answering very, very simple questions about PKD, and you'll be very surprised at the lack of information about some of these very, very simple questions. So again, this was some work done. This was by Simon DeLucian, who's now at the University of Surrey, working with a number of groups, including the PKD Charity, just to look at how many people have PKD in the UK. And this actually is a very, very important figure for a lot of reasons. And he was able to go to a number of GP practices and look at their records. Now, that will probably fill you with horror if you've been listening to the news recently in terms of access to patient records. I'm not going to get involved in that argument, but actually there is some fantastic benefits to having fully informed consent by individuals providing access to records. We can get this sort of information. And essentially what it shows, if you go to a large number of GP practices, and these are practices that covered about 1 million patients, they found about 700 individuals, 50-50 male and female, who had a diagnosis of polycystic kidney disease. And you can see there's a great big splurge in the middle here, that the majority of people with this particular condition were aged somewhere between their 20s and their 40s, but there's a big tail, very young people, elderly people here. And actually when you number crunch, it's about, in the UK according to this, it's about every one person in every 1,300 have PKD. It's probably going to be closer to 1 in 1,000, taking into account the number of people who've not yet been diagnosed. So put that into a much bigger picture, there's going to be 60 to 70,000 people in the UK with this condition. That is a very, very large group of individuals who very clearly, in our view, demand the very, very best that the NHS has to offer. So this is not a small problem. at this recent meeting I was talking about in Edinburgh, it was actually quite extraordinary that you can put, I would like to think, some of the finest minds in the world together to talk about it, but we actually couldn't agree on how you diagnose polycystic kidney disease, yet we all agreed we knew exactly who had the condition. But there are some very, very simple basics about this particular condition. We know it's a genetic condition, and that is manifest in a number of different ways. The most obvious way, if you look at the bottom here, is that we can see it drawn out like this in terms of a family history or a pedigree. It can go from generation to generation to generation. That's very much the hallmark of a genetic condition. We also now know which particular parts of our genetic makeup, our genes, are responsible for this particular condition. And I think the current view is that polycystic kidney disease, in terms of the one that we're predominantly talking about today, so autosomal dominant polycystic kidney disease, is caused by genetic alterations in one of two genes, not very imaginatively called PKD1 and PKD2. So perhaps the best diagnosis, if we did way of diagnosing this condition, if we had really good access to genetic testing, would be a kidney disease that's caused by genetic alterations in these two genes. But genetic testing isn't widespread. We still rely on very, very simple tests to come up with a diagnosis. And the one that I suspect everybody with a diagnosis in this room has had in the past is a simple ultrasound scan. To somebody who is aware of this particular condition, the finding of lots and lots of black holes in what should be a normal kidney here is very, very suggestive of polycystic kidney disease. The kidneys are usually big as well. And so when you see this, and often accompanied by a few, sometimes many cysts in the liver, there really are no other diagnoses that we need to consider. However, if you see some cysts in the kidney, there are many causes of some cysts in the kidneys, but polycystic means exactly that, many, many cysts. If you have a family history of this condition, then it becomes much easier, in a sense, to diagnose it in another family member. And we have some very, very simple criteria in terms of just counting the number of cysts in terms of your age to make a diagnosis in a relative. So in fact, there's no real confusion in the clinic as to whether or not somebody has this particular condition. The tools to diagnose it are very, very simple. So this is a very, very simple, in a sense, cartoon, actually summarizing an awful lot of what we've learned over the last 10 or 20 years. And I'll just go through this very, very briefly. We've already made the point that this is a highly variable condition. We know that there are many, many people out there with polycystic kidney disease who are never diagnosed in their lifetime. We also know that there are people with polycystic kidney disease who are diagnosed in their first 10 or 20 years. And over a period of time, all of that information has really come together to allow us to sort of think about what happens over somebody's lifetime with polycystic kidney disease. And it can be distilled into a very, very simple picture such as this. So, along the bottom, we've just plotted age. So 60, 70, 80, we all get to at least 85, I think, these days. And up the side is kidney function, and that's just measured as percent. What we know is that at a relatively young age, say up to 10, 20 years of age, somebody with this condition is very likely to have normal-sized kidneys with a small number of kidney cysts, which potentially are detectable by ultrasound scanning, not reliably until you're typically in your mid-teens. As you get into your 20s and 30s, the number of cysts that you get increase, and concomitant with that, the size of your kidneys increase. And it's that particular model that we are now starting to understand in more detail, that over one's lifetime, the number of cysts that you have in your kidneys increases and the size of your kidneys increases, such that as you get older and older, your kidneys get bigger and bigger. The amount of normal kidney tissue, as you can see, as you move over to the right, gets less and less. So for some individuals, as you get older, there is then a reduction in kidney function, and I've put that along the top in the red dashed line. For some people, kidney function will stay very good until old age. For other people, that kidney function will start to tail off in your 30s, 40s, or 50s. And what we now know is that there is quite a strong link between kidney size and kidney function, and I'll come on to that in a little bit now, but also into a talk this afternoon where we highlight recent research findings and clinical trials findings. So it's really this very, very simple model of how the condition progresses with increasing kidney size and therefore the increased risk in declining kidney function. And that increase in kidney size also just gives us a better way of understanding what are the most common symptoms and troubles that people with this particular condition would experience. Very early on, people may develop kidney infections or blood in the urine. I mean, we certainly see a significant number of young adults, certainly young men who play rugby, kickboxing, all the things that people do, who present with blood in the urine. That can be quite an early feature. It can often be one of the very first features in an individual. As the condition progresses, then perhaps more people come into clinic who have been picked up to have high blood pressure, perhaps at a routine medical, perhaps because they've been messing about with mum or dad's blood pressure cuff at home, whatever. Others present with different complications, kidney stones, for example, or a sense of abdominal discomfort or back pain or something. So again, we see people who've been investigated for things like that. And that obviously, as your kidneys get bigger, then you're slightly more likely to develop abdominal discomfort. An ultrasound is a very quick, easy and cheap test, and it's often the way that people are now presenting to our clinic. Other people, as the kidneys get bigger, will notice abdominal distension and a feeling of bloating. Liver cysts are also very common in this particular condition, but only a relatively small number of people will get symptoms related to that. And of course, as we get right over to the right-hand side, we know that some people will present for the very first time with impaired kidney function that's been picked up by a routine blood test or symptoms, for example. So we understand much more now how this particular condition is progressing over time. What about monitoring and management? Again, that's something that we are asked a lot about because it may last for many, many years. It is not inconceivable that people will be in a clinic or monitored by their GP for decades. And it's actually quite difficult, and we have this discussion many, many times, to really keep going with that level of follow-up. And in fact, when you look at it, it's not unusual, for example, for somebody who might know that there was PKD in the family not to have started this sort of long-term follow-up until they were in their 40s, perhaps even later than that. So there's lots of very general things that we would look at and discuss in clinic, not just the family history. You're going to hear a lot about the other aspects of this: diet, exercise, smoking, alcohol, drinking, I really mean by fluid intake, and other regular over-the-counter medications to avoid. We will also be keeping a close eye on your kidney function. Whilst it's normal, we could be doing that every year, we could be doing it every 2 years, and we could be doing it in shared care with your own GPs who can do it. And the measure that we often use is the so-called EGFR. That's an estimated glomerular filtration rate. That's a measure of how well your kidney is filtering. And it's very loosely, people interpret that as a sort of a percentage. So 100 would be normal, 15 or less would be very, very poor kidney function, and lots of people in between. But many people will be in our clinic with relatively normal kidney function, so an EGFR of over 60. We will be keeping an eye on your cholesterol levels. We'll be keeping an eye on your calcium and your other markers of bone. We will be looking at your urine for blood and protein and the presence of infection, which we like to treat really quite aggressively to avoid it progressing on to cyst infection and so on and so forth. And blood pressure monitoring is very much at the core of what we will be looking at. If your kidney function has declined to such a state, then obviously we will be putting in specialist medical care in terms of the low clearance clinic and thinking about different forms of renal replacement therapy, dialysis or transplantation, and there are talks on that this afternoon. Most people, when they come to clinic, would have had an ultrasound scan, some an MRI or a CT, mainly for diagnostic purposes. And again, I'll come back on to how imaging is perhaps changing the way we understand this condition. Genetics, very few people would have had access to genetic testing. And again, we can have some discussions about that in some of the breakout sessions. Family screening, a big topic. It's going to be addressed by some of our speakers coming up. But currently, there are no PKD-specific treatments, although there are some recent clinical trials that I will talk about. So, I think the issue is, for this particular condition, there is very likely to be a very long period of routine outpatient or GP follow-up before a lot of these complications are manifest. And that is one of the challenges in terms of looking after people with this condition, in terms of how do you provide accurate information at the very early stages of this condition. But there are some few facts, and I'm going to put a few facts up because in recent years there's been really quite a lot of extra interest in polycystic kidney disease in the UK through organisations such as the PKD Charity, through the renal registry, which collects a lot of data on this condition. So we do have facts now. People ask us, what does the future hold in terms of my kidney function? Well, these are averages. This doesn't apply to everybody. These are averages. We know that for people who do develop kidney failure, the average age for that is likely to be in the mid to late 50s, and that has improved over recent years. So that is a fact. But can we predict that early on? The answer to that is no, we can't at the moment. What about likelihood of getting a transplant if I do develop kidney failure? Well, like many other diseases that cause kidney failure, there is potentially a little bit of a wait, and it's the same for all kidney diseases. So PKD patients aren't being disadvantaged in any way. They're being looked after as well as other patient groups in terms of getting a transplant. However, what we know is that once you do receive a transplant, PKD patients do very well. So in terms of the proportion of patients who are getting a transplant after they develop kidney failure, over a period of 6 years after follow-up, well over half of patients with PKD have got a functioning transplant. And that is great news. I suspect a lot of that is perhaps because of the increasing use of living-related kidney donation. Again, something we can discuss. So I'll finish there, and questions if anybody has got any.
So while we change over the computer,
oh gosh, yeah, sorry.
we do have some time to answer questions.
Could I ask how the statistics for chronic kidney disease in general can be applied to PKD? I ask this because there was a study in, I think, 2012 that gave life expectancies for, it was a Canadian study that gave life expectancies for people with chronic kidney disease, where one could look up age and kidney function and have some estimate of what life expectancy might be.
Yes. I think we're now in a much better position to be able to answer all of these questions. The data I showed you there that we're extracting out of the renal registry, which is in a sense a big database of everybody who is on dialysis or having a transplant, we now propose to extend to everybody who's essentially under follow-up in a kidney clinic, and that's going to, and I'll talk about that a little bit later on this afternoon. But you're absolutely right, collecting accurate information and having an accurate diagnosis on that group of individuals is really important to allow us to build up that information, and that's something we're actively doing. If you just look at the group who've gone on to dialysis or having a transplant, we can and do track those individuals very, very closely all the way through their long-term follow-up. And I think what is quite intriguing from that, certainly if you have a transplant, for example, that the data that is currently available on your likelihood of developing significant complications, your survival, all of those issues that you're looking at, that data is going to become available very, very soon. And it's going to be a UK-specific population that we're able to look at. But it is all down to collecting data. So if we can get the consents and the permissions to collect that data, then we will be producing it.
So the UK Renal Registry collects data on everyone who's on renal replacement therapy, and that is accompanied by a diagnostic label. And therefore you can pull out the cohort with PKD. When you see CKD, that is all comers. So CKD of all causes, and that's how you can differentiate. So we can get specific and general information.
The PKD group actually seems to behave quite differently from the overall CKD group. And I suspect that's because in the CKD group you've got a very substantial proportion of people with other diseases that cause lots of other complications like diabetes.
Okay, so a burning question.
Thanks for the talk. I have two questions. So, is there any evidence of the anticipation in families with a PKD disease? And the second one, is there any evidence of people having PKD in developing aneurysms?
So the answer to that is no, it does not. Okay. So even when you look at very, very large families, there is no trend over the years for the condition to get more severe. What we are aware of is that as time has gone by, we are getting better at diagnosing it. So people are diagnosed younger, but it doesn't mean the condition is more severe at a young age. It still remains incredibly variable. By aneurysms, I'm assuming you're talking about cerebral aneurysms. The data on that, again, is now getting much, much better. So, and it's, I think the general agreement is that about 10%, roughly, of individuals with polycystic kidney disease, if you screen them, if you put them in a scanner, you will be able to detect a cerebral aneurysm. The information that we really don't have is how many people who've got an aneurysm will then go on at some point in their life and develop a complication because of that, which is basically a brain hemorrhage. That data has been much, much harder to do, but the majority, so there's a lot of information that's come out of North America, the majority of individuals who do present with an asymptomatic aneurysm never develop a complication because of it. They stay small and do nothing. So the data is not clear, but it's not something we routinely screen for. There's no evidence that screening is of any benefit whatsoever. We just make people aware that should they develop severe symptoms, sorry, I can keep going for hours, then to present. I'll have to stop, my colleagues.
Could I just add to that if blood pressure is very well controlled, then the chances of having a problem like this are much less. And we bang on about blood pressure in the clinic all the time. I'm sure you're bored to tears with hearing about it, but it's really important, and it's one of the reasons that people nowadays do so much better. Because 50 years ago, we didn't have really blood pressure pills at all. And uncontrolled blood pressure is a dangerous thing. I'm sure nobody in this room has that problem. So in the interest of time, we're going to move on now. Thank you very much, Dick. And you'll be hearing from Dick a little later on about the cutting edge and a bit more about research in PKD.